were not showing up in the hospitals, or they were scared of the virus, and or the services were not as regularly available as previously. So, however, as we've stopped having our other physical meetings, we thought of starting our webinars. And so what we are going to talk about is basically today's breast cancer, and but this is also with the background of the COVID pandemic. So I think without any further delay, I'd like to invite our first speaker, Dr. Amjad Ali from Khyber Pakhtunkhwa. And Dr. Amjad Ali is a pioneer oncoplastic breast surgeon based in Peshawar. And he's going to give us a talk about early breast cancer management. So I invite Dr. Amjad Ali. Amjad, are you there?
Thank you, sir. Thank you very much for the introduction. Let me share the screen first. Right, so can everybody see my screen now?
Yes, we can see.
We can. You can just press F5 so that it goes into full screen mode.
Yeah. There now. Okay. So, Bismillahirrahmanirrahim, Assalamu alaikum. And I want to say thank you to Professor Arshad Chima, Professor Harun Javed, and all the SOSPK team who's behind arranging and organizing this webinar, and also giving me the opportunity to speak on this forum. As we know, this is a very short webinar, and I've picked up only two aspects of the topic which are relevant to the current COVID-19 pandemic situation, which I will touch upon. So the topic is early breast cancer in the current COVID-19 pandemic. And the two areas that I've selected to briefly touch upon, one is the number and the statistics of early breast cancer, which is the impact of COVID-19 on the statistics, plus the impact of COVID-19 on the treatment planning, and how have we been treating breast cancer patients, and has that been affected or not? So first of all, just briefly explaining the terms early breast cancer, locally advanced, and metastatic disease. There are so many ways of describing and classifying breast cancer. So if the early breast cancer is defined as the tumor size less than 5 centimeter, or if the nodal involvement is less than 4, up to 3 lymph node involvement, that is called early breast cancer. If the tumor is more than 5 centimeter, if it's involving the skin or the chest wall, or if there are more than 4 lymph nodes involved, that's locally advanced breast cancer in the absence of metastatic disease. Inflammatory carcinoma falls in this category as well. And then we all know metastatic disease, and by definition, if supraclavicular lymph node is involved, that is by definition metastatic breast cancer. So if we look at the pre-COVID figures, they are not pretty readings to start with. So in our country, unfortunately, 30 to 40% of patients at presentation have metastatic disease, and an equal number have locally advanced breast cancer. And that leaves us around 20% of patients who are in early stage breast cancer. Now, this is like 2 out of 10 having early breast cancer and 8 out of 10 having locally advanced and metastatic disease. And if you compare that to the developed world, where there have been screening programs for the past 3-4 decades, their ratio of metastatic disease at presentation is around 5%. So even pre-COVID, our figures were not great. But with the COVID, we expect these figures to get worse. And we all know, we've been discussing this for a while, and there are two main reasons, very obvious reason. One is the late presentation, even later presentation due to fear of COVID. Patients are reluctant to come to clinic. Patients are reluctant to come to hospitals because of the fear of contracting this COVID-19. And this is going to affect the numbers of early breast cancer, and we're going to see more and more locally advanced and metastatic disease. Also, another factor is the unavailability of the outpatient clinic, and especially in the government sector, in the public sector. We can't blame them because they are bearing a huge brunt of this COVID-19 patients, and we have limited resources. So unavoidably, these cancer patients are suffering because of lack of outpatient clinics availability, and also because of the fear of COVID-19. So the numbers are going to increase. To make this even worse, there is so much uncertainty about COVID-19, so many predictions about this virus have been proven wrong. And I'll just say one, our anticipation of the hot summer effect on the COVID and whether it's going to last a month or 2 months, and also about certain drugs. They've all proved wrong. And the latest estimates are that we're going to hit the peak somewhere in August. We're not even there at the peak of COVID-19. So how long is this going to last, and how long can the patients wait? Well, the patients are already suffering. It's been 4 months. And I think we have to find a way of maintaining SOPs and safe environment, yet providing clinics and facilities for these new patients. Just quickly moving on to the impact on the treatment planning. So just a glance at the different modalities in which we treat breast cancer. There is surgery, there is chemotherapy in both neoadjuvant and adjuvant setting, radiotherapy, endocrine treatment, again in neoadjuvant and adjuvant setting, and then there are targeted and biological agents. So the treatment is affected because of these two main reasons, because there is fear and risk to the patient, and there is fear and risk to the medical staff. Now, what are these risks? So if we take them one by one, surgery-related risks to the patient, we don't know how patients who actually have COVID-19 will behave after surgery. The post-operative recovery is unpredictable. We know so little about how the COVID-19 patients behave. We also don't know how the general anesthesia and the ventilation will affect them, and whether the recovery will be uneventful or not. And this is made even worse by the fact that majority of the cases are asymptomatic. So it's difficult to make out the positive from the negative, considering that the tests we have has a 30% false negative rate as well. So all this adding to the risk of the patient, but also to the risk of the medical staff. And if we come to that, intubation, anesthetists are at an increased risk of contracting this virus, because intubation is a very high risk procedure. And it's been advised to avoid intubation as far as possible. And when we come to surgeons, there is vaporization of tissue, especially when using the high energy devices like the diathermy, and there is risk of contracting the disease from this vaporized tissue as well. So these are the reasons where worldwide surgeries, even for cancer patients, are delayed or postponed. So this is impacting the treatment of the breast cancer patient. Coming to chemotherapy, well, chemotherapy is not without risk either, because we all know that chemotherapy decreases the immunity of the patients, and we already know that patients with low immunity, for example, patient in older age with diabetes, ischemic heart disease, they have poor outcomes when it comes to COVID-19. So knowing that chemotherapy decreases immunity, if patients who are on chemotherapy, they contract this COVID-19, the outcome is likely to be, or feared to be, worse, which is why there is reluctance in treating patients with chemotherapy as well. So is radiotherapy safe then? Well, actually no, because the early advice was to avoid radiotherapy as far as possible. The reason for that is that even with the most advanced techniques, even with the CT plannings and with the Linux use, it is unavoidable to have some exposure of the lung to radiation. Now, radiation-induced damage in a normal situation with these modern techniques is not a big issue, but if somebody contracts a COVID-19 virus, and then on top of that, you add to it the lung exposure or the damage with radiotherapy, there is uncertainty as to how the patient will behave and whether the patient will improve and recover or not. So the early advice had been to avoid radiotherapy as well. So as you can see, surgery is not without risk, chemotherapy is not without risk, and so is radiotherapy. However, endocrine treatment, I think in all this is a bit of a silver lining for the breast cancer patient because it does not decrease immunity, it does not increase the chances of acquiring or transmitting the virus, and it has literally fewer side effects. The limitation is that endocrine treatment is only useful for ER/PR positive patients. And even for the ER/PR positive patient, there is 5 to 20% cases of resistance to endocrine treatment. So where do we go? There is no consensus guidelines worldwide about breast cancer management because we haven't had enough time and because we can't predict a lot of things about COVID-19, but there are general agreements. And the general agreement is that if a patient is ER/PR positive, start them on neoadjuvant endocrine treatment. The way you address the 5 to 20% resistant cases is that if you check Ki-67 of the patient only 2 weeks after the treatment, while the patient is on the treatment, there is a significant decrease in the Ki-67 proliferation index for those who are responding to the endocrine treatment. So if we get that result, then you can continue on endocrine treatment. For the ER/PR negative tumors, which will either be triple negative or ER/PR negative and HER2 positive, the general agreement is that should consider neoadjuvant chemotherapy. And those who have completed neoadjuvant chemotherapy or those who are not responding to chemotherapy, we should offer them surgery with specific precautions. However, that does not address one of our main problems, which we face more than the West, and that is palliative mastectomies. We know that that does not have any impact on survival, but it alleviates the pain and the symptoms. So where do we stand, and should we be offering palliative mastectomies is yet another debate. So just to quickly summarize, COVID-19 has and will continue to impact early breast cancer numbers, the treatment, planning, and also the survival. We need to provide safe alternative to the patient because COVID-19 is unpredictable and we don't know how it's going to pan out. Thank you.